So we are going to the holy grail of ultrasound, those tiny little ultrasound waves that we love so much, and speaking a little bit more about pneumonia and respiratory infections in children. So as we were talking about those possible viral pneumonias that show up on chest x-ray, that's always a little muddier than we like to say. And the question is how can we diagnose these faster with reducing total amount of radiation for these little kiddos in a general basis? So this particular paper was another meta-analysis that we looked at, reviewing some papers that looked at kids and lung ultrasound evaluation for pneumonia versus a chest x-ray. Now, yes, it did in fact use the chest x-ray as the gold standard in many of these, and in most of them a chest x-ray plus clinical findings. Most of them, they were also blinded between the ultrasound findings before looking at the chest x-rays. So the radiologists or the technicians were not biased in that regard. And actually the sensitivities and specificities worked out great for the ultrasound group as well, 96 and 93% respectively. In total across all the board for some subgroups was even better. They also looked at subgroup analysis for the technicians who were performing it, including expert radiologists, expert clinicians, even inexperienced clinicians, including residents who did very well, just as well as the expert physicians pretty much. And so really the principle is that it's a useful tool in this case, kind of a proof of concept that you can use ultrasound, lung ultrasound, if you're doing it right, to identify pneumonia in kids, so that you don't necessarily have to rely on a chest x-ray.
So throwing down the gauntlet. Is the chest x-ray dead? Is ultrasound the future? What do you think, LaShawn?
According to this paper, which is what we're supposed to do, I do not agree that ultrasound is ready for prime time with regards to diagnosing pneumonia in children. And let's talk about why. Let's dig into, you guys know I'm a tad bit of a research nerd, so let's dig into what they actually did. They went out, and this is a meta-analysis, so they did a search to see what articles had already been done, what studies had already been done, and they got 1,475 hits on that, okay? And then they reviewed those titles and abstracts, supposedly, but with 1,400 articles, they likely just read the title. And they went from 1,475 to and kicked out 1,460 of those. So we don't know what those 1,460 papers actually told us with regards to this topic. So they came back with 15 papers that they wanted to review, that they actually read the entire paper and decided whether to include them or not. Half of those got kicked out. So we don't know what those 7 articles said. So at the end of the day, we're stuck with 8 articles that they're giving us that they're saying they analyzed from an initial total of 1,475. Little suspicious. All right, so of those 8 studies, they then went down and said that some were done in hospital settings, some were done in meaning inpatient settings, some were done in ICU, some were done in emergency departments. So of the 8, 3 of them were done in emergency departments. So we're today talking about whether or not this is going to be prime time for us as emergency physicians. And I will use the Donald Trump component as well. Only one of these studies was done in the United States. All right, and that was actually our largest sample size. So for a lot of reasons, I'm going to pick on this one study. It was done in the US, the others were done in Italy and China and Egypt. It was the largest sample size. So for that reason alone, it'd be a good study to kind of pick on with regards to the ones that they use. The sample sizes range anywhere from 28 to 191. And what this one study showed us, and this was one where the actual pediatric emergency medicine physician was the one doing the ultrasound. And that's what we're saying would likely be the case for us. If we're going to do it in the same real time that we would use a chest x-ray, someone in the ED would have to be the one doing the ultrasound. Allow you to get the diagnosis in the same amount of time as you could by just looking at a chest x-ray. So of those 191, 37% of those who had a positive ultrasound, 37% of those did not end up having pneumonia, okay? So what's going to happen in this setting is you've got a subpopulation of kids that you're going to scan, at least in this paper's setting, and say, hey, you've got pneumonia, and they really don't. So what's going to end up happening with that is you're going to end up giving kids that don't need antibiotics. And with our holy grail attending Dr. Wild in the back, we all know we do not want to give kids that don't need antibiotics in that setting. So I think that there's still a lot to be done. If this is something we really want to use, I think a proper study needs to be done with appropriate sample sizes. The largest study only had less than 200 patients, and we used studies that had as many as 28.
Gauntlet thrown. Now
Okay.
what?
So, indeed, there were some problems with a few of the studies. But if you look in total as to what the goal of the paper was, it certainly isn't to say that ultrasound is the new gold standard. It's really kind of a proof of concept. Is this a reliable thing that you can utilize at the bedside so that you don't necessarily have to look at a chest x-ray? The international focus of this paper was partly due to the fact that many places in the world don't have access to chest x-rays. So this is not one that is specifically geared just towards our U.S. emergency departments, but the utility of ultrasound to be in places where there may not be x-ray capability. So it's kind of a proof of concept that you might be able to do it somewhere else. Again, that 37% false positive rate, picking up atelectasis, things of that nature, also going to be picked up on a lot of chest x-rays. There's a lot of reactive airway disease that we discuss with kids that you end up getting atelectasis on a chest x-ray, and you'd like to open them up before you get that chest x-ray. Well, you can catch the same thing on an ultrasound. So if you're looking too early, or if you're looking in young kids, so that study also included neonates. And so if you're looking at these very small neonates, you can start to capture these tiny collapses in the lungs because you're looking at these very small spaces. They may not flourish into a pneumonia. You may open them up before that happens. And then again, because we're not CTing these kids, you're not getting a CT proven or better study to end up getting a final diagnosis of pneumonia. So the picture's kind of muddied in general with that. But in kind of parallel to some of the adult literature that's coming out, where we do look at CT identified pneumonias, and where ultrasound is as good or better in many studies with CT confirmed pneumonia cases than plain chest x-ray, there is a correlation here with the pediatric literature, and this tends to happen from adult side to pediatric literature, where all of a sudden, because of the limitations in pediatrics that we do with studies with different radiation levels and everything else, the literature tends to lag behind sometimes. But again, I think it's useful as a proof of concept that if you're a skilled technician, you know what you're looking at, and you have the clinical picture of the child right in front of you, you can probably put together that they're going to end up having pneumonia, and you can treat them appropriately without having to send them down to get a chest x-ray. Or if you're in an area where maybe you do have a handheld ultrasound, but no chest x-ray capability, you can still diagnose that child appropriately and treat them appropriately.
So I agree that in theory, this is a good idea. I just don't think it's ready for prime time. And the reason why is that we're arguing that you could use this in a setting where you don't have a chest x-ray. But in reality, if you're somewhere where you don't have access to a chest x-ray, you're also not going to have access to a highly skilled sonographer more than likely. So what's going to happen is the studies that they use where they had outcomes that did support ultrasound, they also had a highly skilled sonographer who was actually doing the study. You know, lack of chest x-ray and a highly skilled sonographer don't normally meet together in a real life clinical setting. So I think that it's not likely that you're going to get those two things together. The other thing is, let's look at the limitations that the paper cited for itself. It also cited a significant heterogeneity. So if we want to go back to that topic, that was an issue in this paper as well. And the fact that we had a small sample size, and the fact that each one of these studies was done at a single center, and they were all done in high-income countries. So I think that there is some possibility this could be helpful in a lower-income country or clinical environment. But if that's the case, the study needs to be done in that environment so that we can properly address the limitations and the applicability to that scenario.
We'll let you guys close with why you think we should be using this today. You've got a kid on the ped side who's suspecting pneumonia. Why is it that we should be incorporating ultrasound? Daryl?
So I think if you do incorporate the ultrasound, you get a lot of information immediately. And typically in our hands, we're not just looking for the pneumonia, you're also doing a whole lot of other clinical information that you're gathering from the ultrasound at the bedside at that moment. I think the utility of it in a crashing child may help you. Realistically, most of us are going to continue in this country to get a chest x-ray. but it may help with your skills. And one day you may not have that ability. So I think it's useful to practice it. It's certainly not harmful. And you may be gleaning some other clinical information at the same time. Maybe they have a large effusion, hernia, something else that's going on that you see immediately because you've decided to put the ultrasound probe on.
So I think I agree with Daryl in that it could have ultrasound in children with pneumonia could have great educational value. You may learn something in that setting. But with regards to a clinical setting, I do not think we're ready to start diagnosing ultrasound in children. One, most of our clinical attendings on the pediatric side would not be comfortable doing this for the same reason that the majority of primetime America is not ready to do this quite yet. So I think that in the current setting, if it's actual a clinician in the emergency department ultrasounding, I think that you're still at a point where a chest x-ray is going to give you very quick information for the most part. If it's a crashing kid, you can get chest x-ray there just as fast as you can get an ultrasound there. So I think that according to this paper, if we're going to use this one as a reason for why we should start doing this, I just don't think this paper proves that to us. I don't think that we have large enough sample size. I don't think we have enough information from this to start doing this quite yet.
Based just on what they've told you before we ask you guys what you actually believe, how do you think each of them did? So we'll start with Daryl arguing that we should be using ultrasound to diagnose pediatric pneumonia. All right. And what about LaShawn saying that we should not be using ultrasound for pediatric pneumonia yet? LaShawn, I think you edged it out. Now, before we get a discussion, tell us what you actually believe as to whether we should be doing it or not. Daryl?
So I think it's actually going to be a useful tool. I think it's something that is in its infancy, just like every other bit of ultrasound that we've been doing. You know, we're slowly developing our skills, our skill set. To me, the ultrasound probe is kind of just like a stethoscope. I mean, you listen for crackles, you put it together with the clinical picture, and you decide, oh, they've got a pneumonia. Well, I think you get even more visualization and information out of the ultrasound, and ultimately, most of us in this room won't be able and capable of looking at those things and diagnosing it. Now, do I think that's a reality that's going to happen here in the next coming years? Probably not. Everybody's still going to get a chest x-ray. Everything is readily available here for a chest x-ray. I may still look at a kid's lung and say, I think it's the pneumonia. They're going to go get a chest x-ray as we do it, but I may do it for myself for practice. If anybody is deciding to go overseas, I'm sure you can talk to some of the folks in the back who do, and they diagnose pneumonias and all kinds of other things because they don't have other radiographic modalities outside of the United States. And so it's certainly something that has a lot of utility. And again, at least the way I usually am using the ultrasound is I'm not just looking at that one thing. You're gathering so much other clinical data. I think it's useful. I don't think it's something that's going to be justifiable or that you could say, oh, I'm going to diagnose this kid with a pneumonia and send them home without getting the chest x-ray. Somebody comes back and says, well, you didn't get the chest x-ray, doctor. You're kind of hosed, I feel like, at least at this point.
All right, LaShawn, tell us what you actually think.
So what I actually think is that it's not time. We're not there yet. I think it definitely does have a potential for us to get there, but I think training we'd have to train everybody across the board in order to get to that point. I think it would be a great study to do somewhere like Augusta, Georgia, where you have a educational center as well as you have Doctor's Hospital who's treating little kids and you have university that's treating little kids. And it'd be interesting to see what results you get in different clinical environments with a much larger sample size. I'm sure if you pulled it over a year, you could get a bigger sample size than the whole 700 and something patients that they used in this one paper.